Hello, this is Dr. Scott Worden, the TOS guy. We're broadcasting and live streaming from beautiful downtown Sunnyvale, California. And this afternoon, we're lucky to have one of our most popular guests back with us, Dr. Art Jenkins. Art, great to see you again.
Thanks, Scott. Always great to see you too. Pleasure to be here as part of your team.
We have 5 popular questions that people ask about TOS, and you are going to take it and answer with your usual style and education. Thank you.
Thanks, Scott. So these are questions that kind of come across in the blogosphere, as well as in my office, as well as in other media that we've dealt with. And so I certainly just happy to run through some of these answers, some of which have been heard before, and others which have not. So first, before we get going, I always like to say, first of all, I have no material conflict of interest with regards to thoracic outlet syndrome. I do have some minority ownerships, which we're obligated to describe. I'm also open to other opportunities if somebody wants to give me a conflict of interest. But in the meantime, I do my best for my patients. They're my only conflict. So question number 1, why is TOS, thoracic outlet syndrome, so difficult to diagnose? Well, first of all, it's a very complex region. The shoulder is actually 17 different muscle groups that each of which support the scapula. It also, because it's such a complex area, it interacts with multiple other neurologic problems, whether they be spinal, peripheral nerve, or other medical and other conditions that can lead to confusion for clinicians who are knowledgeable, let alone for clinicians who are not aware of this condition. One of the other problems is that this is frequently an intermittent symptomatic problem. Patients are more symptomatic in one position than another. That makes it confusing for some clinicians or radiologists because they need to be imaged in that particular symptomatic position to really pick things up. Another problem, EMGs are frequently not positive in this group, which confuses people even more, especially people who are not familiar with the problem and the patients. Another reason it's so complicated and hard to diagnose is somebody about 40 years ago decided to call it disputed TOS, or a subset of TOS cases were called disputed TOS. And no doctor wants to get involved or make a diagnosis that's disputed. And unfortunately, what he was really doing was railing against a relatively high in complication rate for the way that people were doing the procedures 40 years ago. But as a result, they kind of set the entire field back by about 40 years. And we're really only getting out from under that shadow now. We have some great radiology studies that clearly show the anatomy. We have a better understanding of the condition. And we also have much better both diagnostics, but also support groups and patient awareness. There's this education seminar that we're talking about, this webinar series. We also have a number of patient support groups. The word is finally getting out. Question number 2, can I be genetically predisposed to have thoracic outlet syndrome? Well, the answer to that is mostly yes. There are certain neurologic conditions that are more common in certain inherited conditions, in particular hyperflexibility. Some patients, whether it be Ehlers-Danlos hypermobility or other types, may be genetically predisposed to having the over-rotation in the shoulder joint that can lead to instability. In addition, we believe that many of these same patients also have a laxity of some of the ligaments and perhaps even some of the muscles involved. This then leads to the various shoulder instabilities that can lead to thoracic outlet syndrome. However, genetic predisposition isn't the only factor that leads to thoracic outlet syndrome. It usually requires some type of an injury or some other type of mechanical wear and tear on that joint, on the shoulder joint in particular. Although sometimes patients who have extensive spine problems wind up putting more stress on that shoulder joint, leading to instability. Ultimately, it comes down to genetic and environmental factors that lead to TOS. But yes, there does seem to be a genetic component. When is surgery indicated? That's another great question. It varies by the patient. We know that the first thing that needs to be done is we need to make the right diagnosis. How can you do a surgery without the right diagnosis? And this is made more complicated because there are multiple subtypes of thoracic outlet syndrome. Those include arterial, venous, and also neurogenic. There's also first rib as well as cervical rib impingements. And then there's even impingement out laterally in what we call the pectoralis minor region. So the first problem is which areas are involved. The next area is what's been done. What have you done already to try to avoid surgery? And in general, I'm a surgeon. I say avoid surgery until you can't. And so we go into therapy to strengthen those muscles. The next step would be bracing of some type, whether with an external brace, like one of our colleagues in the TOS education group, Dr. McIntosh has already been very good at making braces, but other people will also do kinesiotaping. Finally, there are many pain management doctors who've had some success with injecting, whether the muscles that are contributing to the pinching or sometimes irrigating or leading to different injections that can loosen up some of the tissue where the impingement or pinching is going on. And finally, surgery is when those other things that we've tried have failed. They're just not doing it, getting worse or not getting better and staying in an impaired state. So surgery should be done when there is sign of significant vascular impingement. Surgery should be done when there is sign of ongoing nerve damage that may lead to or has already led to permanent nerve damage. And surgery should be done when you need to get on with your life, whether you're a professional or maybe an amateur athlete at a high level, and it's preventing you from doing what you need to do. In cases like that, it's a decision that you make to move forward with a more durable treatment than what you've tried up until now. It's also important that after surgery, more care needs to be delivered. In fact, you want to make sure you re-strengthen the muscles. Once you fix the problem in the thoracic outlet region, you've got to get the arm muscles and the shoulder girdle muscles stronger again, or you're going to wind up having more problems anyway. So what are these surgical options you speak of? Well, the main ones consist of coming from the top of the shoulder and looking down. Here we see the blood vessels and the nerves in the area that consist of the thoracic outlet region here. We have the scalene muscles that involve that often when they're too close together pinch. We have our first rib and we have our second rib. And we frequently will come in from above, take out part of the first rib, do a resection of these muscles, free up this area. There are advantages and disadvantages of each approach, and this is not meant to be an all-encompassing 2-hour dissertation on the comparison. I'm just describing them. The next approach is we call it the infraclavicular, where you're going under the clavicle, and we come in through a small incision here. We reach under, remove the rib from here all the way back to about here, free up the nerves and the vessels, make sure they're not being pinched anymore. It's a different approach, and it does allow for a minimally invasive approach that's relatively low risk. But Once again, this isn't the place to have that discussion. The third major approach is called the transaxillary approach. And this is when the arm is lifted up, we're able to look straight down the vessels and the nerves and get to the rib, which is actually just over the horizon in here. This is frequently used by many of the vascular surgeons because they feel comfortable following the blood vessels into the area in question. But either way, it's just a different approach to the same area. The final major class of treatments of this come from the transthoracic approach. You're actually coming from inside the chest wall, deflating the lung, and looking upwards at the first rib, taking out the first rib from below. You tend to see the area of the thoracic outlet last, so some people don't like not seeing the nerves while you're working around it. But this is the fourth major area. And this is often done by thoracic surgeons or people with experience with robotic surgery. My next and final question, how did you develop your interest in thoracic outlet syndrome? And honestly, I kind of got into it through like a little bit of a back door. What happened was I had done an extensive amount of training and research on operating in this area as a neurosurgeon. I studied peripheral nerve surgery. I studied vascular surgery. I did a lot of minimally invasive surgical training, both during my residency and fellowship and afterwards. Took separate courses with some of the masters in the field and developed an expertise on doing minimally invasive surgical approaches in this general region, either for cancer or for other conditions. And I got referred a patient who had a cervical rib. We developed a new approach for doing this and taking out the cervical rib and relieving the nerve pressure on the nerves here. Patient did great. We published this case report. And then right after that, I started getting all sorts of referrals for other types of thoracic outlet syndrome. Well, I reached out and said to my vascular colleagues, I don't do a lot of this. Maybe you should do this. My colleagues then said to me, we'd like to do it with you because you do a lot of stuff in this area as well. So I first started scrubbing with them, saw how they did it, and said, I got a thing or two I think we can do to make this better. And we then developed a different minimally invasive approach using an operating exoscope, which allowed us to make a very small incision right here, reach underneath, do an infraclavicular approach through a much smaller exposure, which allows some of these patients to go home same day with pretty minimal pain post-operatively. Not everybody, pain is a subjective phenomenon, but it seems to be very effective with minimal risk and maximum benefit. So I got into it because I listened to my patients. And then I listened to my colleagues, and I worked with my colleagues, and we raised the bar. Now, if there's time, I do have one more question that sometimes get asked. Who should do my thoracic outlet syndrome surgery? Should I get one type of specialist or another type of specialist to do it? And I would say it actually matters a little bit less the type of specialist that you should do. Obviously, as a neurosurgeon, I'm a little biased. You should see a neurosurgeon. But I also understand that there's some great vascular, orthopedic, plastic surgeons out there who are doing, and thoracic surgeons who are doing great work. And so the question really comes down to, who do you trust? You got to find somebody who understands the different procedures, someone who appreciates the specifics of the patient's anatomy, and in particular, what would make one choice of one procedure over another if there is an obstruction, if there's a problem or a potential complication to be avoided. So you want to make sure you understand what to remove and what not to disturb. There's a lot of valuable real estate in there, and you don't want to just muck around for the sake of it. You want someone who will actually follow up with you, because thoracic outlet syndrome is not a one and done and you never have to worry about it again. These are frequently patients who have to be followed, that there may be recurrence of some of the symptoms. The symptoms may not all go away completely because we may not have treated all of the causes. There may be spinal problems that are superimposed upon thoracic outlet problems, maybe peripheral entrapments on top of that. So this is often not a one and done, but more of a involvement in a relationship. You want to make sure that the person who is going to do your surgery will explain to you, the patient, the risks, the benefits, the alternatives, and what the likely outcome is going to be based on their specifics. You can't just say everything is the same, because they're not. Every patient is a little bit different. And so you need to make sure you find somebody who will differentiate patient by patient. You're not a piece of material in a factory. You're not a widget. Shouldn't be treated as one. I want to thank you. Thank you all. I want to thank, of course, Scott and the people at the Thoracic Outlet Syndrome Education Group. And if you have any additional questions, obviously you can reach out through the live chat. You can reach out through the various media through the TOS education portal, but also feel free to reach out to us, follow us at various social media locations, whether it be YouTube, Facebook, X, or Instagram, or just go straight to my website, which will actually lead you back to any of these locations as well.
Hey, I'm back. Thank you, Art. That was great. Would you do me a favor? Send me that list of how you choose a surgeon. I like the way you outlined that.
My pleasure.
I have a couple of
I could put that into the chat if you want.
Sure. So I have a couple of comments and questions because, as usual, you make me think more about stuff revolving around TOS. So I took a few notes. You mentioned that the development of the disputed moniker for TOS occurred during a time of higher surgical complications. And is it because there weren't that many approaches, or just there weren't enough experienced people doing it, in your opinion?
I would have to say it's a number of different factors. And I think that one of them is it was, earlier in the era when people were, just experimenting with some of the techniques. We didn't have as much emphasis on some of the outcomes. We didn't have the neuromonitoring that we have. Even the anesthesia was not as good then as it is now. And the imaging was clearly not as good. In fact, actually, I know, Scott, that's a common topic of our discussions, is the need for imaging. And there are some practitioners who believe, and in fact, one of the vascular surgery positions, vascular surgery society positions, is that you don't always need imaging to evaluate thoracic outlet syndrome. And I think that that's a valid criticism of that position, that in this day and age, when there is good imaging available, why would you not want to make sure you image? We don't do exploratory laparotomies very often anymore. We don't do exploratory laminectomies. We don't do exploratory brain surgery. Why would we do exploratory thoracic outlet surgery
Would you
when there is imaging available?
Would you explain to our viewers what an exploratory laparotomy is?
Sorry, laparotomy. That's my bad for not using it's laparotomy. Is the lap is considered the abdomen, otomy is a hole. So when you open up the abdomen surgically, that's called a laparotomy. And so it used to be, in the days of trauma, we would just every major trauma that came into the emergency room with any drop in blood pressure, we'd open their belly to make sure they weren't bleeding out. And that quickly went by the wayside as we discovered, there are CAT scans that we can do. There are little tests we can do quickly where we don't have to open the whole belly. We can just take a peek inside, see if it's full of blood or not. And if it's not full of blood, you just close a tiny hole instead of a big one. But exploratory in general just means you're opening it up without any idea of what you're going to find. It's kind of like being a little bit like Indiana Jones, but even he had a good idea what he was going to find when he went into the Temple of Doom. He didn't just say, "Hey, this looks like a cool temple. I'm going to go explore." He did his research. He knew what he was talking about. And so, not doing your research, not which as a clinician means getting the imaging, getting testing, figuring out what it could be, and equally importantly, ruling out or eliminating possibilities that would put you in a different direction if you knew to look.
So,
So
so you're suggesting that some people do an exploratory first rib resection.
I am suggesting that that's the way it turns out. They may
Okay.
not, they may argue that their clinical judgment is more than adequate. Um, but I would say if your success rate is not, 90,
Mm.
95%, then your clinical judgment isn't.
And we know that isn't. We know patients do fairly well in some of these surgeons' hands, but there's recurrence rate over the first 2 years, so that the numbers pretty much show it at 2 years. About 70% of people are doing fair to great, but 30% of people are not.
Well, that could be for a number of other reasons, including the fact that that TOS does appear in a complex environment. As I
That's true.
said earlier, not every patient who has an initial response of some kind to TOS is TOS their only diagnosis. And
Uh,
so
that's
there's
correct.
recurrence of the same problem, and then there's development of what was maybe more of a minor problem that gets worse after
Mhm.
the TOS is treated. Maybe they get more peripheral neuropathy, or
Or
maybe they had a spine problem all along and a minor amount of TOS, and you treated the
yeah,
TOS, and then but the spine problem was never addressed. So you really got to make sure that you're going to a clinician who both treats TOS well, but also knows to check the entire neural axis to make sure that they should be treating the
a great
TOS
point.
primarily.
It's not just surgical failures, it's a patient selection. If we don't have strict criteria for the diagnosis of neurogenic TOS, then the patients you intake and provide surgery on are going to be a mixed bag and the results will be mixed. So that's a very valid approach to it. You
Yep.
know that in Washington State in the late 80s, early 90s, I believe, there was a guy named Franklin who published a paper for their work comp system. It's called Labor and Industry, maybe. Anyway, they decided that they should never diagnose neurogenic TOS because the surgical complication rate was too high. And I always found that intriguing because
Yeah.
the diagnosis has very little to do with the surgical outcome in that regard. You should do the diagnosis, in my opinion. Then
And
you can
just
approach.
raise the bar on the surgical
Right.
treatment instead of not making the diagnosis in the first place. That would literally be like saying, we're not going to diagnose TB anymore because we don't have good TB drugs. Well, just
Right.
the opposite. You need to make the diagnosis, show how often it's poorly treated, get industry or the professions to weigh in and raise the bar rather than take away the bar.
Yep. It was very advantageous for them because they had to pay out less disability, et cetera. So it was
Yeah.
convenient. Um, the injections you mentioned, and I just want to emphasize what I know you were getting at. You're not a fan of sending someone to pain management because you can't figure out what the disease is and just put them on opiates for their life. You were talking
Oh,
about using injections for positive approaches.
correct. In general, as a surgeon, I like to fix things. And so my favorite way of interacting with pain management doctors as a surgeon approaching a treatable, fixable problem is to have them involved in diagnostic tests. Is this the pain problem? Does an injection in this location give me relief that maybe a second injection in a different place doesn't? Then that allows me to differentiate which one is the pain generator and which one is not. Um, Obviously, if somebody has a pain management injection that cures a problem, which there aren't too many, then obviously I would send somebody for an injection over a surgery any day of the week. However, most injections don't cure problems. They only put a band aid,
Mm.
metaphorically, on the problem. And in some cases, while the band aid is applied, the patient heals themselves. Rarely does that happen in TOS because TOS is more of a chronic problem. It's more relevant in, say, disc herniations, where
Mhm.
somebody might have a disc herniation, and 3 to 6 months after the herniation, the body has reabsorbed
Mhm.
most of the disc
Right.
fragment. It's a different entity than TOS, which is a gradual settling and more progressive, more symptoms over time. You don't get better on your own. You don't get better without some type of directed treatment. And
Break
so
break the cycle.
injections don't break the cycle. They only give you pain relief if it works, and diagnostic information if it's not a long-term solution.
And we're talking about things like scalene blocks and pectoralis minor blocks for our viewers.
And nerve gliding and
Right.
other things like that. There are people who are doing everything from stem cells and PRP to
Right.
hydrodissection and other things like that. My experience is those rarely give more than transient relief. There is no clear insurance level, i.e., it's so strong that even insurance companies who don't like to pay for things, there's no insurance level approval, there's no Medicare approval, there's no industry approval. There is only, people who are. Some people have published some limited series, but there's
Mhm.
no blinded study that compares one treatment to another that shows any superiority other than surgery. And there are surgical comparison series, um, but no comparison series that I know of that randomly assign patients either to injection therapy versus
Mhm.
surgery therapy.
Well, I'm hoping and keeping my fingers crossed that there is promise in these approaches. And as you mentioned, that you can use them in conjunction. For example, you improve the nerve gliding, you do an anterior scaling block, and then the patient can advance in their physical therapy. That would be the sort of thing that would take patients
Correct.
out of the
And
surgical loop.
that's one where the injection didn't cure the problem, but it
Mm,
gave the patient the opportunity to try to cure the problem themselves.
exactly. Very good. And then the last question is kind of a philosophical question. After your first case, the cervical rib, and the microsurgical approach, you had other people approach you. This is not the first time we've heard this story that someone does a case of TOS and a whole bunch of other docs start referring to him or her. Do you have any feelings why that takes place?
I think it's easy. There's Most people aren't comfortable either with the diagnosis or with the surgical treatments, and so they're very happy to send patients elsewhere that they themselves aren't comfortable taking care of. And that's good, in the sense that you would rather have somebody admit, I don't do this, but that guy over there does. What
Yep.
bothers me is when I hear stories of somebody saying there's nothing wrong with you, you don't need any more treatment, don't go get more opinions. That's I'm very happy to tell I mean, I'm not happy anytime I don't have the right answer, but I will always tell a patient, I do not know, go find somebody else. And sometimes people say, well, who should I go see? And I'll say, I don't know, because I don't know what the problem is. If I don't know what the problem is, I can't tell you who to go to, but don't give up looking. And it may be a failing of the medical profession. It may just be a failing of the fact that we have not learned everything about everything yet, which isn't truly a failing. It's more of an incentive to try harder. But you know, I know
Yep.
every patient out there wants an answer. Not every patient is going to get one, but every patient will get a good, earnest effort if they go to the right place.
Yep. And unfortunately, there are some docs who can't say, I don't know.
Yes.
So we need to get past that. Awesome. Can we take a few questions here
Sure.
from the viewers? Awesome.
Absolutely.
Let's see if Herb's going to put them up or if I should just read them. There we go. Let people read it. A question about the veins. All right.
And I'm going to shift my screen around for now. Hold on one sec. Okay.
All right. You want to answer this question about veins in the chest after a first rib
Well,
resection?
I would say it is not unusual for people without thoracic outlet syndrome to have blue veins that appear in their chest. There are a number of circumstances where you get veins that come out. Veins can become more prominent with any vascular increased vascular pressure, but they can also just be visible in certain people with varicose veins, just in general. Some skinny people often have veins. People with light skin color often have veins that are visible. We know that, for example, there are a lot of people who are pregnant and their veins get very dilated and visible throughout much of their body, and they don't always go away. So it's the answer is that it kind of depends on each patient, and it certainly is a question for this individual patient if she's already had surgery. And I'm basing she based on the Wow Latina name that suggests Latina, and more power to our Latinas out there. But it is something for you to ask your surgeon in particular if they know as well. It could be a sign of something, but it could just be that's your new normal.
I don't know of any papers that talk about the presence of chest wall collaterals from a venous blood clot and how often they disappear. Just as you said, you acquire it through pregnancy. Well, this person, I'm guessing, acquired these venous collaterals because they had an obstruction of the vein, thus why they had the first rib resection. So to the patient, I think the most important thing, to add to what Art said, is get an ultrasound, make sure it's in different arm positions. If the blood is draining correctly through the subclavian vein and you haven't had episodes of blood clots, then it's just cosmetic and a lot less worry.
And
Thank
there
you.
are other conditions besides pregnancy and TOS that can lead to venous collaterals developing, including May Thurner and other pelvic obstruction. So there could be other things going on. And as I said, that's why it really should really talk to your doctor and dig deeper. And if there are any other symptoms that you're having, maybe bring it up with them.
Something is a good point. Something like superior vena cava syndrome. So this is a bigger vein than the subclavian vein to our viewer. And if you got a stenosis there from having a central IV line in place, you could theoretically develop an obstruction of the largest vein leading back to the heart. Now, this would tend to show up on both sides as venous collaterals.
Right.
But yeah, definitely
But
get your
May
doctor to do
Thurner
ultrasound.
syndrome is also a syndrome that can cause various vascular recollateralization, and that's another rare condition that's poorly understood. So
Thank you for
there's
the
it's
question. Herb, who's next? MTY Maurice. Is it possible I have, well, I'll let you read it. I'll let our viewers read it because I always hate when people talk over the question.
sure. So the question is positional. Arm pain certainly is suggestive. Having it in the hands, but all five fingers, is one of those things that raises a couple of red flags that it may not just be TOS. It could be TOS and something else. We traditionally talk about TOS as being a condition of reaching, and so some of that is here. But we typically also see it more in the ulnar distribution of the hand rather than all five fingers. That doesn't mean there may not be impingement upon other nerves, but when we talk about the parts of the nervous system that are affected by TOS, it's more often the lower trunk, proximal part of the brachial plexus that's impinged, and that tends to reflect mostly in the C8 and T1, mostly C8 distribution, which is this part of the hand on both sides. C7 is much more the middle finger region, and C6 is primarily the thumb. There is some overlap on finger in the middle, in the second and fourth fingers, but it's also important to differentiate. Maybe it's not TOS, or maybe it's TOS plus something else. So really need to get a thorough evaluation to answer that question. But certainly if you're having consistent neurologic symptoms, get it checked out.
And we can help you find a TOS specialist if you reach out to the TOS MRI website. Thanks. SA. All right. You can answer it. I'm decided to stop reading the patient's questions because they know what they're asking.
All righty. So, mild and intermittent pain, 2 out of 10. Um, that comes down to a question for each individual patient. There are some people, you might be a professional athlete, where the 2 out of 10 pain is limiting your ability to be at your 99th percentile of function. Or if 2 out of 10 pain is after you've taken narcotics and other medications, then maybe that's actually a bad place to be. But if it's 2 out of 10 and you don't ever even take Tylenol or Advil or anything like that, honestly, although it's a personal choice, I would probably recommend against surgery for that level of pain. But I would also say that some people's 2 is another person's 8. And, you know, it's a very personal question. It wouldn't hurt to get an opinion and have somebody talk to you about what that really is, because the details do matter of what is a 2 out of 10 pain. Is it 2 out of 10 pain plus weakness? Is it 2 out of 10 pain plus severe numbness? Maybe it's only intermittently painful, but maybe you're dropping things with your hand. That's a totally different story than my strength is perfect. I use my GripX testing, and my GripX is phenomenal. 98th percentile for my age, and I work out regularly. Somebody like that, I'd say just try to do exercises and try to stay on the non-surgical spectrum until you can't. So it's a personal question that I can't answer for you without knowing more details, and the details do matter.
Thanks. And we obviously we don't give specific um, diagnoses here. So without some other data, as Dr. Jenkins was just describing the different patterns of nerve root involvement, you should have a professional, have your primary care doc start doing a basic neuro exam. Okay, no joke movie. Long question. Okay, we can take long questions. Okay.
Keep going.
Okay, so without going back to my library, I'm not going to comment on a paper. I'm
Yeah,
happy to
I would say that would be more. That's a very academic discussion, um, and I would say that when a paper comes up with the conclusion that there is no evidence for its use, no evidence is a very strong statement. I would say that they may not consider whatever evidence to be valid. I'm also not super strongly against use of Botox, at least initially, but I would also say it is a toxin. It is poison. We are putting it in to make muscles stop working, and it needs to be used very carefully by very skilled clinicians, because there are a number of very vital structures in the area that can be significantly and durably affected. Most importantly, the esophagus. You don't want to have trouble swallowing just because they're treating your TOS. And by trouble, I mean you can get serious swallowing problems that can last for months, if not longer. Um, However, in the right hands, Botox into the scaling muscles can give some short-term relief. And there are some who believe that repeated injections of the Botox toxin into the muscle can lead to repetitive paralysis and atrophy, and ultimately reduction in size of the muscle, which can cause less compression. However, um, once again, I'm not convinced that it's a permanent, durable treatment option. For many patients, they wind up doing it once or twice and they just don't like getting repeat injections, and they wind up going on to surgery anyway. So that might be part of why they say there's no evidence for its systematic use. But I think it's a difference when you look at the verbiage of what their conclusion is. And as Scott said, without reading the actual specific article, and I admit I don't read every single article that's published, I will actually say there's a lot of garbage articles that are published nowadays. There are too many journals. There are too many journals that are inadequately uh, edited. In fact, actually, the Hindawi Publishing Group actually had to retract entire collections of journals that had questionable results
Mm.
published. And so you really need to look closely at the journal itself, who the authors were. There's a lot that goes into the evaluation of any article to see whether it should change or affect your management. And so, as a patient, I would say no one article should ever be definitive, and no one clinician can ever claim to be the final and definitive expert on any subject.
I'll add a few points to what Art has discussed. First of all, we're not making a specific diagnosis for you, but here are some general tips you should consider and some comments about what I see when I read these papers. Number one, they often select a population of patients with neurogenic TOS that I don't consider accurate because it's the clinical diagnosis. And we know that those tests, like a Ruse test or an Adson's test, are not great. Secondly, we all know in the field that it's a complex disease and it's different in every person. So some people might respond very well to a Botox or lidocaine injection, a short acting anesthetic, because they have problems arising in their anterior scalene. But there are other people who have different issues, postural positions, or pec minor issues, or fibrous bands, or abnormal anatomy of the plexus that goes the wrong route. So it's hard in these patients who are clinically diagnosed. If that's the case in this paper, I don't recall it off the top of my head, but they may start with a heterogeneous patient population, and therefore it would be impossible to get a great result because there's too many different things going on. Another comment is, in general, I think a lot of docs try to do an injection in one site at a time. Now, I don't know if you've had all 4 injections done at once or just one sequentially and wait for the results, and it takes a while. Botox takes a while to work. That's a more effective thing because, as Art said, you want to find the pain generator. So you can't do that if you're injecting multiple sites. Then if the patient feels better, which injection was it? Or was it all of them? So that's a general approach I take. I'm going to go back and look at the paper, but as I said off the top of my head, I don't recall it. So when you look at papers like this, understand the patient selection may not be just all the same, may be very heterogeneous patient population. And for that reason, the outcomes are hard to judge. But I appreciate the question. I think it's a very high level question. Thank you. If you want more information about your personal injections, please consult with us through tosmri.com. We do have a consult service and can get into more detail. Okay. And we saw this question. Okay. All right. So we're going to stop here. Art, thank you again for your time preparing for this and for all your thoughtful comments and education.
Happy to help, Scott. And I thought I'd throw in that 6th question just in case there was room to grow, shall we say?
I love it. It's good to have an organized approach like that. And I think those points were all very well taken. All right. So again, I am Dr. Scott Worden, the TOS guy, and we are sponsored and helped out by toseducation.org. And my website is tosmri.com. And you can find Dr. Art Jenkins in New York through his social media that we showed previously. Please go back to that point in the video and reach out to Dr. Jenkins. Again, we're happy with all the questions and the contributions from people. We're going to ask everybody, hit the like button. That helps us a lot. Subscribe if you haven't already subscribed, and hit the little bell so that you get notified when we do a new video. Thanks again. Everybody have a great day.
Take care, everybody. Goodbye.